My name is Stacey Lintern. I'm the Executive Director for Ontario and Nunavut. I have the pleasure of facilitating this panel discussion. Research shows, as we've heard throughout the day today, that proper respiratory care can extend the life of people with neuromuscular disorders and has a significant impact on a quality of life. In December 2012, Muscular Dystrophy Canada, in collaboration with various partners and key stakeholders, released the paper Case for Support for Respiratory Support. If you would like to review it, it is on our website at www.muscle.ca. The paper identified a number of key areas of concern that require further attention to ensure that optimal respiratory care is accessible for all those who are affected by neuromuscular disorders. This included lack of research and education and consistency. When not properly prevented, respiratory failure and associated ventilation is associated with major cost to our healthcare system. A lack of awareness among healthcare providers, and barriers with publicly funded systems to support ventilated individuals in the community to be available include timely access to equipment and care. In a few minutes, we'll have an opportunity to hear from our spectacular panelists today, who will bring a very different perspective in all of these different areas and share some innovation and some creative solutions that they put in place to address some of the barriers. So for today, for the panelist presentation, I will introduce each panelist. I do have some questions that I've created, but I'll also open it up to the audience as well. So I think what we'll do is we'll start with our first panelist, and that is Raj Coli. Raj Coli is a registered therapist at West Park Healthcare Centre. Over the past 16 years, he's taken on a variety of clinical and coordinating roles. In his current position, he is the clinical practice leader for respiratory therapy as well as the clinical coordinator for the long-term ventilation strategy. He is responsible for coordinating a number of local and provincial initiatives, including the Toronto Central Lynn Critical Care Pulse Strategy, OTN Personal Computer Video Conferencing Follow-Up, Pediatric Transition Program from Sick Kids in Holland Blue Review, Transitional Home Ventilation Coordination, and CAVC Care Coordinator. So with no further ado, Raj.
Thank you, Stacey. I'd like to thank you for inviting me to come speak with you guys for the next few minutes. For many of you who may not be from around here, I'm not sure how many of you guys know what West Park is or where it's even located. So let me just give you a few little details about where I work for the last 16 years. So West Park was founded in 1904 as a TB sanatorium, and it's located on 27 beautiful acres here in the west end of Toronto. You actually can't see it from much of the main roads, which is located at Jane and Weston, so it's a bit of a hidden gem when patients actually show up at our door. We have 487 long-term care and rehab beds, so we are not an acute care facility. We do not have an emergency department. We do not have an intensive care unit. We also have 10 community living apartments, which help transition some of our patients back into the community. In 2007, we were dedicated as the Long-Term Ventilation Center of Excellence. I'll get into that just a little bit later. So we do a multiple number of things here at West Park, but I'm going to focus specifically on the long-term ventilation. So there's a number of services that we offer our patients and the community for our local community as well as for the province of Ontario. The first is we operate a 36-bed chronic ventilator unit for trached and ventilated individuals. This is known as our CAVC. When I started about 16 years ago, this was 8 beds. So you can imagine how much has changed over the last 16 years. As part of our home vent assessment and training program, we manage over 350 ventilator-assisted individuals in Ontario. These individuals who live at home or live in the community are on non-invasive ventilation such as BiPAP, mouthpiece ventilation, or they're trached. And our real goal with that program is to provide ongoing reassessments to these patients. So we follow them on a regular basis. They come in, we keep them overnight for 1 or 2 nights and make sure that their ventilation status is good. We also provide 24-hour support for these patients. If they've got questions when it relates to their ventilation, whether it's equipment or whether it's other questions, they can call us at any given time. One of the newer programs, and one of the things that I'm very excited about, is our Transitional Home Vent program. And this is a collaborative effort that we've started with West Park, working together with all the ICUs, the CCACs in the community, and other health service providers. And the goal of this program is to help transition those patients who are currently in the intensive care unit, who will be long-term ventilated, both invasively or non-invasively, and help them move into the community. That means taking them out of the intensive care unit, which, as we all know, isn't the best place to be, especially if you're medically stable, and the only reason why you're in the ICU is because you're ventilated. And what we do is we help get these patients into the community by using linkages that we have, such as with Tobias House or with CCAC, to provide the training and support for these patients to move out. And that program has been very successful, and Yona will talk more about that program. One of the programs is also a pediatric transition program. As we know, much of patients have to transition eventually into adulthood, as much as the pediatric population doesn't want to. So we help move these young adults to go from the settings such as where they've been used to, such as sick kids or Holland Bloorview in my case, and get them into the mindset of working in the adult centers, which, as you know better than me probably, is very difficult and challenging, and at a time for great stress for families. So one of the big features and one of the big concerns I have, and we'll talk about this a little bit later on again, is follow-up. How do we actively follow up patients to make sure that they don't end up back and emerge? So one of the new innovative things that we've started at West Park, and it's only been about 8 months in, is we've been providing our transition patients, once they're in the community, with laptop computers. These laptop computers have special software from the Ontario Telemedicine Network, and we actually webcam them every 2 weeks. So they have a complete follow-up with our multidisciplinary team on our end, which may consist of a physician, but there's an RT, a PT, a nurse practitioner, and we essentially webcam the family, the caregiver, maybe CCAC nursing in the home, to help identify any new problems that we can help prevent ICU or emergency room visits. So if we find a problem, we'll send a team in, or we'll make a proper referral in the right time so they don't end up in emerge. And that is very exciting, and it's been very, very successful as well. So let me talk more about the Long-Term Ventilation Center of Excellence. So this, like I said earlier, was appointed to us in 2007, and it basically allowed us to spread some of the knowledge that we have here at West Park and provide a provincial resource to the rest of the province. So we do everything from providing education and training to individuals, families, and caregivers. We go in and provide health service provider training to different agencies across the center who may be working with ventilated individuals. And we also provide consulting and outreach services to these organizations. And this service is free of charge. For those of you that may be requiring this service, you could reach out to us, and there's no charge for that. And there's been lots and lots. We've, I think, trained over 50 organizations in Ontario, specifically on how to manage and keep patients safe at home. We also launched a website in 2007. It's now going to have a new face, and that is ltvcoe.com, so Long-Term Ventilation Center of Excellence. And basically, this is your one-stop shop. And here you'll have the ability to take some of our online modules. We've created, I believe, 7 or 8 of them. And they're interactive online modules covering everything from basic respiratory anatomy to tracheostomy tubes, how to manage trach tubes, how to manage non-invasive ventilation, how to manage vented patients, what happens in a typical day in the life of a vented patient who lives in the community, a slew of different resources for everybody, and these are free of charge if you go to this website. And this website has had over 16,000 people from around the world take these modules over the last 5 years. I actually, you should go to them because they're very, very, they're done differently than, this really boring PowerPoint slide. It's all interactive. They use cartoon characters. Everything's animated. There's questions, there's answers. You take a quiz, you get a certificate. So it's been a great resource. And we use it actually as a precursor to any of our ventilator training. So if we're going to come to your organization or to your home to do training with you, the requirement is that you take these modules first. It gives you a good basis, and then this training is much better for you guys. It's also a great place for you to get in touch with us as well if you have questions or concerns, or there's different links to different resources that may be of benefit to you. And here's the list of them. As you can see, they are quite diverse, and we're launching 2 or 3 more modules specifically on pediatric transition as they relate to vented patients. Thanks. Sounds good. Thank you.
Thank you. Thank you, Raj. I'm now going to introduce our next panelist, and I've had the pleasure of working with our next panelist for many years. She is Yona Frischman. Yona has been in the social services rehabilitation field for over 30 years. She started when she was 3. Working with people with disabilities, families, service agencies, volunteer, not-for-profit organization, and advocacy groups. Yona has extensive experience in the provision and evaluation of services to persons with disabilities, and brings a varied work experience in the development, implementation, and evaluation of innovative, consumer-focused, community-based service supports. Yona?
Good afternoon. I'm Yona, and I'm very pleased to be here this afternoon and introduce Tobias House Attendant Care Inc. to you. And although we are called Tobias House, it's not a house. We are a supportive housing organization providing attendant care services to consumers in their own home. For those of you who've never heard about us, it's an introduction. For those of you who heard about us and don't remember, it will be a refresher. And for those of you who heard about us, my apologies that you have to listen to me. I will start with just some highlights about Tobias House. Tobias House is a not-for-profit charitable organization. We have been in business for the past 20 years. We receive our funding from the Ministry of Health through the Toronto Central LHIN. We are a 24/7, 365-day service provider. We are in Toronto. We have 3 locations, and currently we provide services to 42 consumers. Our services are provided by ILAs, Independent Living Assistance, and we adhere to the philosophy, to 2 philosophies. We adhere to the philosophy of independent living and aging at home. And our services all our consumers are adults. I will go into a little bit more details about each one of those aspects. As I've mentioned, we are in Toronto. We are at Toronto Central East. And as a principal, our units are all fully accessible. And we are never more than 11% of the general population of a building. According to Stats Canada, the prevalence of a disability in the population is 11%. So if a building has 250 units, we will never exceed more than 11%. Our units will be never more than 11%. You can do a quick calculation. 250 units, it will be 27.5 units, but we'll round it up. Our units are spread across the building. It's not congregated on one floor or one side of the building, and so on. In each building, we have a staff office, and where our staff congregates between bookings and is available 24/7 at all times. It's a shared service, so it's built on individual needs and allocated time per individual. So the services we provide are assisted living, of course, attendant services, which include personal care, eating, housekeeping, meal preparation, feeding, hygiene, and so on. We also provide shopping services. We either do the shopping on behalf of our consumer if it's the weather is miserable, or we always encourage consumers to shop with us. We also provide attended outreach services on a fee-for-service basis to individuals in their place of work, school, if they have to attend meetings or attend conferences. We also provide nurturing assistance. It's support to parents who have a disability in the care for and cannot care for their children, especially in the early stages when the child is very dependent on the parent. We provide nurturing assistance. Tobias has a resource center that is available to everybody in Metro Toronto, and we assist individuals with self-advocacy, completing forms, and we provide some workshop on different topics. We also run, in partnership with the City of Toronto, the barrier-free swim program and 4 swimming pools across Toronto. We provide the attendant care support for the consumers, and it's open to the public. Presently, we have 42 consumers. 6 out of those consumers are on long-term ventilators. 3 are muscular dystrophy. And we are expecting our 4th to be arriving soon. The age range of our vented consumers is between 28 and 53. And over the years, vented consumers have stayed with us between 12 to 19 years. So what are some of our guiding principles in the provision of services? Because we adhere to the independent living philosophy, consumers have to be able to direct their own care. So they have to tell us what they want, how they want it done, when they want it done. Our services are gender specific for personal care. We do not hire agency staff to fill vacant shifts. What we do is, and we are a unionized environment, so the way if somebody calls in that they cannot make a shift, we look at our seniority list and we fill the shift with one of our employees. And when new employees arrive at Tobias House, they are trained in all locations, so they know all our consumers. Our service recipients are called consumers. They are not called clients or patients. And as I mentioned, they are not congregated in any one building. They are spread in all 3 locations. Therefore, when we hire new staff, male or female, our mandatory training, of course, is first aid, CPR, back care, and vent training. So all our staff is receiving vent training. Our new staff, of course, receive at the initial stage that they come to us. And we do have every 2 years a refresher course for the ones that are not using it as frequently. Now, you would ask me, so how do you ensure safety in the community? They live in their own apartments. How do you manage to make sure that consumers are safe and secure in the community? One of the things we always do is make sure that there is an emergency generator in all the building, especially after a blackout. All our landlords, and we have 3, have acquired emergency generators. We also make sure that our consumers have their spare batteries always filled. So we check them, so they will be filled. Our staff, because it's a shared service, they may be on a booking when they get an emergency call. So they all carry emergency phones for immediate response. Again, our ongoing training of staff and refreshers on ventilators. And each one of our, because it's self-directed care, all our consumers on ventilators will train staff individually because everybody is so unique and so different. We also provide escort to medical appointments and accompany consumers to emergency when they have to go to the hospital. We have realized that emergency staff really doesn't know what to do with the vented consumers, so we definitely accompany our consumers. And for nursing support in partnership, of course, we work with West Park. And we also work in partnership with CCAC for all nursing supports, for medical nursing support. Thank you.
Thank you, Yona. Now I have the pleasure of introducing Sakina Sandicott. You might recognize Sakina. Sakina is on our, and a beautiful family is within our respiratory guide. Sakina is an independent, strong-willed woman and mother. Sakina is an excellent advocate and has worked with Muscular Dystrophy Canada, being involved in the respiratory guide and our annual report. Sakina's input has assisted Muscular Dystrophy Canada in its efforts to enhance awareness and influence positive change.
Thank you, Stacey. Good evening, everybody. I'm actually the face to the whole discussion today here. I use an LTV ventilator, invasive ventilator, through a trach. So, being ventilated, I have understood that there is very limited resources and information specific to people like me. I have lived in the community with a ventilator, and I have defied all odds for last 8 to 10 years, which was very unsafe, but thanks to my lovely children, I have come this far. I would like to highlight some issues that we face living in the community being ventilated. Firstly, it's the limitations with attendant care. So we require 24 hours support, and covering overnight support is an ongoing challenge. Provincial policies that cap hours of support raise a barrier. People like me on vents, we are bound to need someone trained 24/7, which includes nights and all visits outside the home. This not only adds to the cost, but also the need for maximum trained attendant care. We can be faced with a situation where we are unplugged from the ventilator and we are in a crowd, but nobody can help us, and we can't talk and can't breathe. Eventually having to live in a facility or to be a burden on your loved ones. Secondly, I would like to see the challenges with ADP through the provincial government that include denial of necessary equipment. For example, external power batteries. Years ago, when I was ventilated full-time, I was walking then with a rollator, which was then modified to hold my ventilator. That time, we had the very big, bulky LP6s, which was hard for me to push. So I tried all convincing to get the smallest ventilator, which would make it easy for me to push with the rollator. But unfortunately, I was moved to a wheelchair modified with the ventilator on it. And so I lost function in my legs sooner than it was needed. Even now, the ventilator equipment pool, according to ADP, will not want us to be on external batteries. They're very rigid about repairs and swapping the batteries. Ultimately trying to say that we must not move around or do normal activities. The third thing I would like to highlight here is ongoing paid physio support to assist in managing progression of neuromuscular disorders. People with MD or neuromuscular disorders have an indefinite excessive need for physio, which is so unavailable and expensive. This makes us more vulnerable to our illness. And if we have a progressive disorder, we speed up our deterioration and ultimately fall back on the same system with greater dependency. And lastly, I would say that we need an increase of resources for people like us so that we can travel outside the home to work or on holidays or whatever reasons, not be bound to a bed just because we are ventilated. Thank you.
Thank you, Sakina.
Thank you.
Our last but not least panelist is Tracy Ryan. Tracy Ryan is currently the Director of Services for Atlantic Canada of Muscular Dystrophy Canada. She has been in the role for 5 years and is based in New Brunswick. Prior to taking on this position, she had been working in the field of mental health for 16 years in the areas of education, awareness, and advocacy.
Thank you very much. So anybody who knows me knows that I'm pretty excited about today's activities and the whole movement towards respiratory care. They're probably tired of hearing me talk about it, but I'm really excited about what we're doing and the movement that we're creating. So I'm going to just talk briefly a bit about what we've been doing in the past and our current activities and what we plan to do in the future. But first of all, which way do we go? This way. First of all, I'm just going to talk a bit about a case story, and this is Matthew. He lives in a small town in New Brunswick, and his family is very involved with our organization, luckily. And about a year and a half ago, Matty was airlifted to the IWK in a crisis, and he had pneumonia and he had a collapsed lung. And we were notified actually through a local firefighter who was also connected to the family, and they let us know right away that he had been hospitalized. And immediately we made a connection with the family, and we made phone calls, and we did visits to the hospital to see how they were doing. And the family were really, really stressed. They were really concerned because they weren't sure about the care that he was going to be receiving. That they felt that some of the staff weren't that aware of the effects of neuromuscular disorder with oxygen, and they were really concerned. And the reason they were concerned was that they had attended one of our family retreats just 3 months prior to the crisis, and in that family retreat we held a session on respiratory care, which Lori Gillis actually hosted that session, and she spoke about oxygen and the impacts of oxygen, and that resonated with the family because Matthew was becoming delirious, he was confused, and they remembered Lori saying that how that can cause delirium and confusion when they're not checking oxygen levels and having too much oxygen. So we were able to connect with the family, send information to the family. We were able to connect through our national resource. We contacted Marla, who connected with some of the local resources here in Ottawa, or Toronto and Ottawa, and we were able to send information. So we were able to reassure the family that they were in good hands. But having said that, they were in good hands as long as the respirologist was in the room, as long as people who were aware. But at every shift change, a new team would come in and they would increase the oxygen levels, and the same thing would happen over and over. So they had to continually reassure or inform the staff on what his needs were as a child with a neuromuscular disorder. In the end, everything worked out well. He did have a lengthy hospital stay, but he did leave with a prescription for a cough assist machine and a BiPAP, and was followed by the local company in his region, so it all worked out well. But the piece, I guess, that's most profound here is that had they not had the awareness, we're not sure how if it would have, had such a positive outcome. We'd like to think it would have, but you never know. And I guess the big piece too is that they were just so startled because this was considered a center of excellence, and yet they were still, a lot of the staff who were dealing with him weren't up to speed on the concerns around neuromuscular disorder. So it worked out well. Our network worked out well. So it all turned out really well in the long run, but it just shows that there's still lots of work to be done in terms of educating our families and educating the professionals that are working in the field. So looking back, in the Atlantic region, we've been kind of involved with a number of activities as far back as 10 years, really. The former director that was in my position 5 years ago, she had really created a strong foundation and was starting to work with professionals at Stan Cassidy and other vendors and professionals in the region. And she said to me, when you take on this job, there's many things to do, but you need to focus some attention on respiratory care. That needs to be done. She was working strongly with some of the folks regionally, and she had created that foundation. So I took heed and I got involved, and it worked out well. So, but in the long run, they had been doing education sessions for quite some time, up to 2003. Into 2008, they were holding sessions again in partnership with Stan Cassidy, both for professionals and for families. In 2010, we continued with the movement. We're into Newfoundland, we're into Nova Scotia, we did New Brunswick, and we just kept going with the education. In terms of systemic advocacy, they were highly involved with a movement in New Brunswick, which Muscular Dystrophy Canada took a lead on and connected with, again, professionals at Stan Cassidy, other organizations, allied health organizations like Canadian Paraplegic Association, and families. Families really got involved with the movement around access to equipment. And it was a long haul, it was a long road, it was, that started, I think they created a position paper with the Premier's Council on the Status of Disabled Persons in 2006, and it was 2008, late in 2008 before any progress was made, but in 2008 they announced a new program, the New Brunswick Oxygen and Breathing Aids Program for the folks in New Brunswick, and it had $1 million investment from the start, which was a tremendous effort. But really, it was the families that really took on the championed the cause, that met with every level of government you can imagine, and just wouldn't take no for an answer in terms of gaining access to equipment. So they really created a wonderful model, which we hope to recreate in other provinces, and we continue to do that. And now we're working with other officials in the Department of Nova Scotia. Lisa and Jeff and I have been working for the last couple of years, and again, trying to create a movement down there that a model that they could follow, like as is available in New Brunswick now. Again, we're continuing with our partnerships and networking. We're trying to create strong working relationships with each neuromuscular clinic, and I think that's happening across the country. That is certainly the strategic direction, but we've been doing that. Again, working with Joe Foote and Colleen O'Connell to gather information for the document that we have today, and we're always giving updates to all the partners in the field in terms of what our progress will be. In Ontario, the same. They're working with the local health integration networks which has a focus on community supports for people who rely on breathing assistance. And I know there's groundwork being done and out west as well, and looking at surveying what the services are out there. So, no, wrong way. So as Stacey had said, in 2012, it became a priority for Muscular Dystrophy Canada, and Sonia was hired and did the document and built the case for support, which Stacey touched on some of the key highlights that were available in that report. And certainly that has helped us as service directors, I guess, to focus our attention on what we're going to do next and next steps. And we do have a wonderful group of services staff who are working together and connecting on a regular basis to see what types of things we're going to be doing in the future. But of that, when Sonia did her research, 2 programs were highlighted, and one of those programs in terms of equipment access was the New Brunswick Oxygen and Breathing Aids Program. And then in the West, it was the Provincial Respiratory Outreach Program, which provides key services like 24-hour telephone support, respiratory care services, hospital discharge planning, respiratory equipment pooling, and outpatient in-home visits. So those 2 would probably the most premier programs that we'd like to see duplicated in other provinces. And it's not going to be easy to get that. It's going to take time, as it did in New Brunswick, to get things approved, but we are hopeful if we start planting seeds that we'll get there. We're hoping anyway. So this is the document. It is available on our website, as Stacey had mentioned, so I encourage you all to go and take a read. There's some great information in that document, and lots of hard work was put into that document. So where are we today? So today we have the handbook. Thank you again, Joe, for the work that you put into that, and Marla and the services team who all had a hand in that. It's going to be a wonderful piece, a wonderful guide that will guide the work that we're going to be doing in the rest of the country. In terms of the Atlantic, we continue to do more education sessions. We did some in Moncton, St. John this past year, where we had Dr. Bach brought in to do professional training with both professionals in the morning and then a family session in the afternoon, which was terrific. We're partnering with March of Dimes Canada to hold other sessions. We did one in Halifax. We have one upcoming in PEI in Newfoundland again in the fall. I know there's others planned throughout Ontario as well. In Quebec, they're working closely with the Quebec National Program for Home Ventilatory Assistance. So we have some things happening there. They held some education sessions as well with the pediatric pulmonologist and respiratory therapist this past spring, which was recorded and is available on the website, I assume. And again, they did another education day with the pulmonologist in spring as well, so they held two. So the next steps will be the rollout of the guide, and there's some work to do, I guess, on what that will look like and what kind of training we'll be doing with professionals in the future. But we do know that it is critical that we continue with the training both for our families and for the professionals that are working in the field, and to get them talking with one another and using the best practices that were discussed today. So more coming in the works. In terms of equipment funding and advocacy, still lots to be worked out there. We know that access to equipment, it's wonderful to have this information, but if you don't get access to the much needed equipment, then, you know, where are we? But we know it won't happen overnight, but I certainly encourage you as families to get on board, to learn about the equipment that was talked about today, to get a plan like Joe talked about, and to really, if you have the capacity, to get involved and meet with your local healthcare team, meet with the powers that be in terms of funding sources within government, and just don't take no for an answer. I mean, the business case is there, the numbers are there. As services directors, we can help with how you do that. We have an advocacy toolkit. We have wonderful literature already found or evidence in the guide, and so we really need your help to move this strategy along. In Ontario, again, they're partnering with the Ontario Health Care Organizations. The Western area is going to be surveying respiratory care programs with their local health authority and mapping that a bit. And then we'll continue to partner and bring on partners as well with the systemic pieces, because we're such a small organization. We know we can't do this alone. We need the voices of other allied health agencies that have concerns with respiratory health and other folks. So that's where we're at in terms of that. Yeah, so I guess we just want to continue with the work we're doing. And Jeff's going to come up. Did he come up? Jeff's going to come up, and he's just going to give a brief, he's going to tell us a little bit of some recent experiences he had to just, again, heighten or to further reinforce the need for more education.
Thanks, Tracy. Tracy's asked me to tell you a little bit about two recent experiences I've had in dealing with crisis situations. About a year and a half ago, I realized I should be in crisis and end up at the hospital and not be able to communicate on my own, or not have my caregiver there to communicate for me. So I had a medical alert bracelet made that outlines all of the risks around oxygen, anesthetic, and with all my wishes. About 6 months ago, I ended up in an ambulance on the way to emergency in respiratory distress. First thing I said to the ER nurse was, I have a medical alert bracelet. You call this number, they'll give you everything you need to know. Luckily, I was still conscious. I had to tell her 3 times to call medical alert. People think that that's the first thing they look for in an emergency department, and it's not. Finally, after 2 hours, I convinced the nurse to call the medical alert. 10 minutes later, she came back and said, wow, that was really cool. It just baffles me that this rethink is common sense, and it doesn't happen. So it shows that you really need to advocate for your needs when you're in an emergency situation. About 2 months ago, I ended up back in the emergency department, unrelated to my respiratory care. I had to stay in the emergency overnight. When I fell asleep, my oxygen levels started to drop. When that happened, the alarm went off. I didn't have my ventilator with me because I went to the emergency in the evening. The alarm went off. They called the respiratory therapist. The respiratory therapist came, and I told her, I need to have a BiPAP. Sorry, we don't have BiPAPs in the hospital. How about we put some oxygen on you? I said, no, we're not going to do that unless we have supported ventilation. That was fine. A few hours later, I was admitted to the hospital. When I was admitted, I told the nurse I had the risk of oxygen therapy. That next morning, respiratory therapy showed up at my room and said, oh, I see you don't have an oxygen meter on your wall. Let me go find one. I then 3 people I had to tell about the risk, and it wasn't listened to. Luckily, I live in a small community, and the respiratory therapy school is located in that hospital. The next day, the instructor came and said, we recognize this is an issue. Will you come and speak to our students? And hopefully that will be happening in the next few months. So once again, it's very important for you to recognize that you need to have a plan and ability to communicate when you could be in a crisis situation. Thank you.
Thank you, Jeff. So I will now proceed with some questions for our panelists, and then I'll open up to the floor as well too. But I do have some questions. The first one, and I'll open it up to the panelists, and you can respond. What would you identify as one of the major challenges for optimal respiratory care for people affected by neuromuscular disorders? Any volunteers to go first?
Sure, I'll talk.
Thank you, Raj. Thank you, Raj.
I mean, I think for me that there's lots of different challenges that wrap around neuromuscular disorders. One is education. Education, I think, is critical, as we just learned the importance of being able to recognize when there's a problem and trying to take a proper approach when you're treating a patient in crisis. But even before then, I think the most sort of kind of a message from the talks from this morning are around lung hygiene, about breath stacking, about the importance of lung volume recruitment and how important that is to keep your respiratory health in check, even before you get to the stage where you're looking at a non-invasive device or if you decide to be trached. And then the second challenge I find is the follow-up. So great, you know, you've gotten to the stage where you need either non-invasive or invasive ventilation. You're able to get home, you're living at home in the community with your loved ones, you're not in the intensive care unit, that's all great. How do we keep you safe there? How do you keep yourself safe there? How do you prevent those emergency room visits? Is there things that we can do as healthcare professionals to help prevent that? I think those two are kind of top on my mind.
Great, thank you.
As witness to living in the community with invasive ventilation, I believe the biggest challenge we face is having attendant care which is trained 24/7. So you have to have your family look after you, your friends look after you, because really we don't have provision enough to have 24-hour care for people like me.
As a service provider in the community, I think there is a lot of fear by individuals to go to a service provider in the community. There is a lot of hesitation and a lot of mistrust. I think that our individuals have been cared for in the medical profession in hospitals, in segregated environments, and going to the community is such a hurdle to get over. And also there is, I believe, also an air of mistrust that community service providers don't have the skills, don't have the knowledge, don't have this, don't have that, to continue appropriate support in the community.
I think that probably access to the equipment, like financial access, because it's very costly. So I think even when people have health insurance, even the 20% copay is quite high on some of these pieces of equipment, which some of the vendors could attest to. And yeah.
Next question. What innovations have you used in addressing the challenges that you've just shared?
Guess I'll go first again.
Thank you.
I'll address both separate. So education is important. So I think what we've done here at West Park is we've put together originally paper packages that were given to families that were interested, or organizations that were managing or caring for ventilated individuals. And then with the onset of the web, we then progressed to online modules to help disseminate the message to people from, I guess, well, for the province of Ontario and then eventually around the world. And that's sort of a clear, concise, consistent message. The packages are consistent purposefully. They all match our training that we do with individuals, families, and other health service providers. Follows the modules, which follows the paper copy, and I think that's important to get the message across in a clear, concise way. So that's for the education piece. And then for our next challenge of follow-up, you know, we're using that OTN technology, which is again brand new and is just up and coming. But the ability with everyone having computers at home, having access to the internet, being able to do these secure webcasts with families and caregivers 24 hours a day, 7 days a week has been critical. Families now with patients who are ventilated at home, if they have a problem with their piece of equipment, sometimes, I'm an RT by background, and sometimes we get calls in the middle of the night and someone's describing a specific piece on the ventilator that's broken. And all you want to do is, could I just see the picture? And I'd be able to tell you. So with the new technology, we're able not only to see the patient and ask them questions. Yes, we can't do clinical examinations, we can't do physical exam, we're not doing monitoring, we're just looking at what the patient looks like. But we can also look at equipment, look at the pieces that don't work, look at what the ventilator is doing, and then offer as much support as we can over the phone. Of course, that won't replace in-house or in-hospital assessments. Those are important for many other reasons. But we're hoping by having this, you know, bi-weekly follow-up with the OT, with the nurses, we can, you know, address situations that are getting to this point where, you know, that if we didn't address them soon enough, it would end up in an emergency room visit and may end up in an ICU visit. And we all know that's not the place where we want to be. It's not the best place for anybody. So that's how we're handling those two situations. And we'll see with time if that has made a significant change. But I can tell you, for the 8 or 10 patients that we have on the follow-up with the OTN computers, it's been very good.
I will agree with Raj totally that education and awareness is the most important, but really what worked for me is self-advocacy. So every time the doctor said, you can go home, Sakina, you can get out of the facility, I defied her and I kept on going. So I think only self-advocacy is the best bet.
Ideally, as somebody is graduating from West Park or a hospital bed and so on, I would like to see a transition to our services. So they come to visit us, they spend time with us, but it's not possible. It doesn't happen. So what we had a young man transitioning from hospital to our services. And what we did, we were flexible. So instead of arranging the supports in the traditional way that we are arranging regular bookings, we assigned 2 staff to that young man to be with him for 24 hours. Instead of one change, a major change is already that you're living one environment and going to another one. And you don't want people coming and going, people coming and going. So what we have introduced for 3 weeks, there were 2 of our frontline staff assigned 7 to 3 and 3 to 11, and allowed for the transition for this individual, and I think he's doing quite good. I would like to see a more partnership between the medical profession, hospitals, with the community services. The other thing we did is we trained all our staff on the new equipment that this young man was going to use. So even individuals that don't work in that location, we got trained, just in case that they are called to fill a shift. And I think it was quite an experience. So my message is, if something changes, think out of the box and be a little bit more flexible.
I think in terms of Muscular Dystrophy Canada, I think some of the innovations, and certainly what I've heard today, is just around the lack of access to equipment and the lack of funding. And one of the things that we decided as an organization was actually across Canada, and really based on the lead from Atlantic Canada, to cover the costs and offset those costs. So I know for Ontario alone, in terms of the great work that Marla's done around getting some different foundation money, and from our donors, for sure, we've been able to offset the costs of at least 15 cough assists this year, which is amazing. So I think that's a big innovation for the organization. My last question: what recommendations can you offer for optimal respiratory care for people affected by neuromuscular disorders? Raj, do you want to go first?
Sure. I think the most important piece as an individual is to be educated. Be aware of what's available to you. As we learned this morning, there's many different ways to handle different situations, and I think you have to make the most educated decision that works best for you. What works best for the person beside you might be different than what works for you. And to be knowledgeable, to be aware, to be involved in your decision, be an advocate. I think that's very, very important. Don't settle for an answer, that you're not ready to hear yet. Explain why. I mean, there's reasons why some patients can be non-invasively ventilated. There's reasons why other people have to be trached for medical reasons, but understand the reason why before you make that decision. I think that's probably the most important.
Great. Thank you.
This morning, Dr. McKim suggested that people on ventilators cost the government almost $250,000 a year. If we were let out in the community and was considered special and given extra funding for full-time attendant care, physio, and equipment that we needed to live on our own, I think we would reduce the cost on the whole.
I echo, definitely the cost in the community is significantly cheaper, and I think the quality is very valuable for the individuals. But definitely be educated and ask questions. Don't accept all the answers that are given to you. Just ask more.
For me, it would be education as well, again, and then once you were knowledgeable of what to do, gain access to the equipment and then use the equipment. Don't let it crow dust like Jeff Sparks' machine does at his house. He's getting better, he tells me anyway. Yeah.
Thank you, and I'm glad to hear education, because I think that's the purpose of us here today. I think, there's been some really valuable information that's been shared. I think that what I heard, which was great, that it really aligns with Muscular Dystrophy Canada, it's about, making sure the information, the education is out there so that people can make informed decisions about their own personal situation. So it was really exciting for me to hear that throughout the day. That's the common theme. I would like to open the floor for any questions that any of the participants may have at this time. Nothing? I think we were pretty thorough in our questions then. So I did want to take this time just to thank our, oh, we do have one, sorry.
So my only advice is when there is a respiratory problem or, you know, if your child says, I can't breathe, don't take him to the doctor. But if the doctor does not make sense what they're saying and he's not getting better, don't take any kind of, you know, oh, he'll get better, we'll give him anti-inflammatories. Get a second opinion and get it checked and get it taken care of. And don't leave that emergency room until you have all the answers. And you know what? It's your kid's life. You fight for them.
Thank you for that. And I think what we heard as well today, that it's really important to be informed now and not wait for that crisis, so that when, you know, if you do have to go to an emergency room visit or, you know, an ICU, that you can be part of that decision-making process. So thank you for that comment. Is there any other comment or questions? No? Okay. Well, I'd like to take the opportunity to thank our panelists. I think that each panelist brought a very unique and valuable perspective in terms of the services and supports, and also living with, you know, the requirement of breathing assistance. I think that our panelists have shared some very valuable information about their own personal experience. I think that we heard lots of innovations, and I think that's exciting as well too. I think what we've learned through this process is that we need to come up with some innovation and creative solutions on moving forward. So I just want to give the panel the recognition they deserve. They did a great job.